name is Dr. Amol Ganvir. My topic is pigmented paravenous chorioretinal atrophy and multimodal imaging in it. Introduction. PPCR is characterized by the RP degeneration, chorioretinal atrophy, and pigmentation along the retinal veins. The retinal atrophy is characterized by the loss of outer segment of photoreceptor, outer nuclear layer, inner nuclear layer. Though the etiology is not known, the many inflammatory and infectious causes have been associated with the disease, including sarcoidosis, Behçet disease, syphilis, measles, rubella, and tuberculosis. Fundus autofluorescence, structural OCT, OCT angiography, ERG are used to find out the details of the disease. There is no specific treatment to it. My purpose was to analyze the clinical features of PPCRE by OCT angiography, structural OCT, FFA, fundus autofluorescence, and ERG. So, 18-year-old female patient came for routine eye checkup. We incidentally discovered the bony speckle along the retinal veins in both eyes. Patient was known case of TB. We made a clinical diagnosis of PPCRE. Patient had a normal color vision, night vision. The both eye base corrected vision was 6/6. Anterior segment was normal on slit lamp. We performed autofluorescence, OCT angiography, structural OCT, full field ERG, and visual field. So this is the right eye fundus photo, which shows the pigment clumps at the paravenous area. The fundus photo of left eye, which also showing the pigment clumps over the paravenous area. This is a fundus autofluorescence, which show the hypoautofluorescent area, which correspond to pigment clumps. This is the ERG findings. The pattern ERG, which show reduce the P50 response and P95 response, which P50 response is basically suggestive of macular photoreceptor, purely cones, and N95 suggestive of mostly ganglion cell dysfunction. The light adapted ERG, which shows the reduced A and B waves, which basically which suggestive of reduction of cone response and inner retinal layer response by B. The dark adapted ERG, which shows normal ERG. A visual field shows a localized scotoma, which correspond to the lesion. OCT macula was normal. Inner retinal layers and outer retinal layers was intact. This was the OCT we took over the lesions, which shows the absent of the nerve fiber layer, alteration at the ganglion cell layer. Hyperreflective foci was seen in the mostly in inner retinal layers. Absent of ellipsoid zone, the RP atrophy and absence of choriocapillary layer. The OCT over lesion, which correspond, which showing same findings. There is the whole eye angiography of right eye. The OCT angiography of whole eye for right eye, which showing the flow wide area along the paravenous area. This is a superficial plexus, which showing the altered vessel density and flow wide areas, which corresponding to pigment clumps and around the paravenous area. This is the superficial plexus over the macular lesion, which looks okay. This is a deep plexus over the macular lesion, which show some flow wide area over here. This is the outer retinal choriocapillary slab, which showing the flow wide areas around the paravenous lesion. The choroid, which shows the lesion which corresponding to choroid atrophy. The choroid, the choriocapillary lesion over the macula, which shows some flow wide areas. These are studies which conducted which state the importance of multimodal imaging in PPCRE cases. Mostly OCT-A finding, which previous in study suggested altered vessel density in the deep capillary plexus, choriocapillary region. And this study, Ratnesh Ranjan suggested normal flow at superficial and deep capillary plexus and choriocapillary. But in our study, we found flow wide areas in superficial plexus area and altered vessel density also, and few alterations at the deep plexus and choriocapillary slab. From that conclusion, we concluded that multimodal imaging is important to in PPCRE case to know the severity of disease, though there is no grading for severity. OCT angiography demonstrates the impairment at the level of choriocapillary and superficial capillary plexus, and few alteration at the deep capillary plexus, which could have created the changes in the nerve fiber layer, ganglion cell layer, outer nuclear layer, and outer plexiform layer. Alteration at the level of choriocapillaries in the OCT-A and choroid thinning in structural OCT may represent the key factor in the pathogenesis, which is not known properly. So limitations of our study was only single case study. So that's why we do not conclude like our finding and confirm. Need long follow-up to know disease course, and OCT angiography was not done on follow-up because it's a costly suggestion Further studies are warranted to analyze the vascular alteration occurring in PPCRA or longitudinal follow-up. Thank you.
So next presentation will be by Dr. Apurva.